Hey guys, how you doing? Frank Gonzalez, G&G Productions, bringing you another video. Today we're talking about protocols, specifically RSI out of the Lee County Common Treatment Protocols, the newest revision. And it's not really in the Lee County Protocols, but it is. We do have one in my department in the Sterile Rescue. I'll put it up on the screen now. That's what it looks like there. And I'm going to be reading directly from it. I know sometimes there's some confusion on which medications to use on what dose, just because we don't use it as often. So I'm just going to read it straight from the protocol so you guys can just listen to it and make notes. If there's anything you want to know further, like if you want to leave any comments, please do that as well. So here we go. RSI, rapid sequence intubation. So rapid sequence intubation may be indicated in the following situations. Goal is to reverse hypoxia if present and not cause hypoxia during the entirety of the procedure. So if they are hypoxic, we don't want to make them even worse by getting blindfolds on or getting the sidelines on and not realizing that we're not ventilating the patient. As you have seen before, some people get so entranced in intubating that they forget to bag the patient. Their SpO2 levels just go down the drain. So when progressive airway management is unsuccessful in regards to reversing hypoxia and or ventilatory respiratory failure, that's when we're going to do it. Again, another one, toxic gas inhalation or burns with airway involvement and inevitable loss of airway. So if they're able to control their airway or if they've inhaled toxic gases, that's one of the indications of when we're going to do RSI. And lastly, unconscious patient with trismus. Trismus, we know, is the locking of the jaw. It's the involuntary locking of the jaw due to sometimes brain injuries or other medical conditions. But the way to unlock the jaw and tube them is we're going to relax them, paralyze them, and then stick a tube down their throat. All right, so our basic life support actions. Block 1, pre-oxygenate the patient for 3 to 5 minutes. We're going to do oxygenation pre, during, and post, and SpO2 needs to be monitored at all times and documented. We want to use a non-rebreather mask at least at 25 liters per minute, a nasal cannula mask using separate O2 source at 6 liters per minute. So we want to put them on a non-rebreather and a nasal cannula at 6. And if they're not breathing, if they're apneic, a BVM at 15 liters per minute with a nasal cannula. Get a load of this at 15 liters per minute under the mask. And that's for apneic patients. So apneic patients that you're breathing for them, you're going to use a BVM at 25 liters per minute with a nasal cannula underneath it at 15 liters per minute. Nasal cannula, that's right on the protocol. Establish or maintain an SpO2 of 95 or greater. We don't want to get to 100. It's bad for some reason, so we want to stay between 93 to 95, 93 to 99. Insert airway adjunct if needed, i.e. an NPA or an I-gel. Most common I-gel size is a size 4. That's for every common size person out there. And we should have suction ready. If we get in there, stimulate a cough reflex or a gag reflex, we want to be ready to suck out all that vomitus out of the airway. Our advanced life support actions. I just read the BLS actions. Now we're going to do the ALS actions. Pre-intubation sedation. We're going to sedate them. Our primary first-line drug for conscious sedation for RSI is ketamine. And we're going to give ketamine at 1.5 milligrams per kilogram IV push. If we don't have ketamine, we're going to use etomidate at 0.3 milligrams per kilogram IV push. Our pre-intubation sedation or pre-intubation paralysis, we want to paralyze them. We're going to use rocuronium, 1.5 milligrams per kilogram IV push, or succinylcholine, also known as anectine, at 2 milligrams per kilogram IV push. So again, we're going to sedate them with ketamine at 1.5, and then we're going to give them rocuronium 1.5 or sucks at 2. And then our post-intubation sedation to keep them gorked out, keep them not from waking up and prevent them from choking on the tube. We're going to rebolus with ketamine, 1.5 milligrams per kilogram IV push, or a combination of fentanyl with Versed. Our fentanyl dose is 1 microgram per kilogram IV push with Versed at 2 milligrams IV. It's not a weight base, it's just 2 milligrams of Versed. And only, here's a pearl or caveat, only if systolic blood pressure is 90 millimeters or higher. That's when we're going to give the fentanyl and Versed cocktail. The preference on post-intubation sedation is going to be your ketamine and rocuronium. That's a note on the bottom. Your indications for doing an RSI is your status epilepticus, 1 continuous seizure that has gone on for more than 10 minutes uninterrupted, or several seizures in a row that are unable to be broken by basic anti-seizure medication. Multisystem trauma, a head injury with GCS less than 8. If you guys remember from EMT or paramedic school, mostly GCS less than 8, intubate. So they're not breathing adequately enough, so anything less than 8 respirations per minute, we're going to intubate. Patients with trismus or clenched teeth, as I said earlier, trismus is the involuntary locking of the mouth or the jaw, and we're going to relax and paralyze them to open that jaw up and stick a tube down there. Burn injuries with upper airway involvement. Remember, that's also a critical burn area. Any respiratory involvement, critical burn areas, we're going to tube them because there is the possibility of the alveoli being burned. So we're going to knock them down and tube them. Our contraindications to RSI. Contraindications. Predicting difficult intubation, you open their mouth and you see a Mellon Patty score of 4, meaning that all you see is just a big old tongue in there, or you get an overweight, obese person that looks like just a head on a torso with no neck. You know that's going to be an insanely difficult intubation, right? So don't even try it. Any major facial or laryngeal trauma, they took a steering wheel or a windshield to the face, we're not going to try that because that trauma could be destroyed, or that anatomy could be destroyed, so we're not going to try for that. Patient cannot be assisted with BVMs. You're getting poor lung compliance with BVM, so that indicates that there might be an obstruction, so we want to clear that obstruction first before we stick a tube down their throat. Use caution when using succinylcholine choline in ages less than 2 years of age due to potential bradycardia. Succinylcholine choline stimulates the vagus nerve, which causes slowing of the heart rate, so just be aware of that. And then your pearls down at the bottom. ETT confirmation, visualize the ET tube passing through the vocal cords. So don't guess if it's going down the right hole or not. Make sure you visualize those vocal cords. ETCO2 and lung sounds with SpO2 readings. Remember, our ETCO2 readings have to be between 35 to 45 millimeters of mercury. Our SpO2 readings anywhere between 94 to 99%. And then we want to get good lung sounds left and right with absent epigastric sounds. If hypoxia occurs during procedure, stop the laryngoscopy and use a BVM to reverse hypoxia. No brainer, right? Monitor your SpO2 levels. If after 2 attempts of ETT is unsuccessful, consider a supraglottic airway. Go back to the iGel or an OP airway. I prefer the iGel. It's just a little bit more secure airway. Remember, iGel 4 is the most common size. Every procedure must be reviewed by medical director and or designated officer. So every time you do an RSI, it's going to get QA'd. So make sure your documentation is on point, right? That's about it, guys. Short and sweet. 1, 2, 3 medications, 4, 5 medications that we could potentially use for RSI. Ketamine being primary for post-sedation, rocuronium being your pre-intubation paralysis, and then your post-sedation is we're going to rebolus them with ketamine. Simple dosages, simple medicines. If you have any questions, please let me know. Comment down below if you'd like. Don't forget to hit the like and subscribe button. If you have any questions or you'd like to see the videos on any other protocols, please let me know. Until then, that's it. Fred Gonzalez with G&G Productions. We'll see you in the next one. Thanks for watching.